right. So I think we ended on this case last time. All right. So, Robert, what do you think of this?
All right, so we have a 14-year-old with left pelvic pain with sports, and there's a lot of edema in that left ischial tuberosity. So be concerned for a traction injury or maybe even an avulsion injury.
Right. Yeah. So that was a traction injury at the hamstring origin there. Yeah. Sometimes if the bone isn't really clear, sometimes you have to get a CT scan to see if anything's displaced. Okay. Tayson.
All right. Left hip pain, 11 months. Again, I see traction and edema at the left ischial tuberosity. Maybe the right one as well. It's less pronounced. Uh, is this is that pectin? No. Obturator? Injury?
So this is a PDF said, right. You can just see some hemorrhage out into the adjacent muscles. Also known as Van Eyck disease. Okay, Elior.
Okay, 18-year-old male with several weeks of pain after a soccer injury. I think the problem's on the left side. Looks like there's a maybe a displaced bone. Is it from the ischial tuberosity?
Right. And
Okay.
here's that left hamstring attachment. You see it's avulsed off the ischial tuberosity here.
But I hear maybe.
Yeah. See a little bit of
Definitely,
edema
yes.
here. There's a separation, and here's the displaced bone. Okay.
That requires replacement.
Yeah. And this is what it looked like on the plain film. So sometimes plain films are helpful. So this is a paper looked at the correlation of MR findings from and symptoms in hamstring injuries. Typically, symptomatics are associated with increased T1 and T2, common for both. And then you also look for increased tendon size, surrounding edema, and tuberosity marrow edema. And if it's a proximal tendon avulsion, then early surgery is recommended for attachment. Obviously, if it's displaced bony avulsion, like we just saw, that's typically surgery as well. If it's a muscle tear, as is typical, they're non-operative. Can't really suture muscle. Robert.
All right, we have a 24-year-old with possible hamstrings tear, and it does look like there's edema in the left and maybe a little fluid hematoma there.
Good. T1 and there, the PD fat set sagittal, we can see the fluid and the edema and associated muscle. And if you look here, there may be a little bit of interruption in the signal of the tendon here. And so that's a tear. Now, if we, I remember this one's, I don't know why this isn't working. Forget it. Okay. So now if we look in the axials, we can follow the tendon here. Here we can see a little bit of edema, and then as we go down, we can see more edema, and then this is the tendon within the the biceps femoris muscle. And if we start here, we can see the tendon looks pretty normal, a little tiny bit of edema around it. As we go more distally, we can see more edema, but now we're seeing a little signal within the tendon. The next cut, this is the tendon. We can see the lack of low signal intensity. We can see more edema around it and increased signal intensity within the tendon proper. And then if we go farther down, the tendon is abnormally thickened in this location with a lot of increased signal intensity. And here we can see actually a fluid collection where there actually should be the intramuscular portion of the tendon. And if you keep going down, we can see that this is that tendon tear. Now we're starting to see the tendon reconstitute distally there. And here we have edema, and that's the intramuscular portion of the tendon. So this patient has an intramuscular tendon tear. This is relatively small amount of actually cross-sectional volume, but this would be, if you use the British classification, this would be a C, and you'd either be, 3 or 2 or 3. But in this case, the C is actually the significant finding when you see an intramuscular tendon tear, because that increases the time out of sports to 6 weeks plus, which is what they're really interested in, is knowing how long the athlete is going to be out of sports. Okay, Elior? Robert, you had the last one, right?
Yes.
Elior?
Yeah, so looking at the hamstring tendon on the right, we see a gap in the tendon. Yeah, I'd call this a partial or maybe a full thickness tear.
Full thickness or no full thickness, you'd have to look at all the images.
Yeah.
Yeah. Hamstring avulsion. Now, there's a lot of debate about when you have small displacements like this, and I've seen patients treated conservatively, and I've seen patients operated on with these. I even one catcher for the Angels a number of years ago, who was a pretty well-known player, tore his hamstring here, had about 4 centimeters of distal displacement. They elected not to operate on it, and he was actually back playing professional baseball 6 weeks later. So there's a lot of debate, but generally, if there's displacement more than a centimeter, many people believe that these should be operated on right away and fixed.
One of the problems is how do you attach it?
Yeah, tell us, John.
Well, if you don't have any bone to attach it with, and all you have is muscle and maybe a little.
Well, this would be the tendon avulsed off the bone.
Yeah, a little bit of
tendon.
tendon.
Yeah, so you have some.
You may be able to attach it. If it's 4 centimeters, you probably should try it, but you're taking a chance.
So if it's a small one like this, maybe a centimeter displacement, you would treat it conservatively.
Right.
Okay, good. I've seen a
So
lot.
it doesn't matter whether or not like how many components of the hamstrings complex are involved or not.
John?
I didn't quite catch that.
Yeah, I was just asking, does it make it surgical or non-surgical whether or not, like, 2 out of the 3 tendons in the complex are involved, or 1 out of 3, or?
Yeah, I think it depends on the symptoms. It depends on how long it has been, and it depends on the patient.
Yeah. Generally, if the this varies a lot, but generally, if the displacement is over 2 centimeters, it usually involves all 3. Not always. I've seen some where just the biceps femoris is torn and significantly displaced. Uh, so,
And I'm sorry, in this situation, we don't have an X-ray to look at, number one, and we don't have a CT scan, which I think I would get
okay,
to see what I can suture.
okay,
If I cannot suture it, I'm not going to work on
yeah.
Okay.
it. Just conservative treatment.
Yeah, usually there is tendon here. I don't show it in these images, but
Well,
we do.
I would make
Usually there
sure
is
that
tendon.
there is an
Yeah,
arthroscopically you can do that and not cause too much harm.
okay,
And if you can repair it, go ahead.
good. Okay. Okay. Robert, is this yours?
I think it's me.
Oh, I'm sorry, Tayson. Go for it.
Well, it looks like, uh, yeah, the entire hamstrings complex is avulsed, and yeah, just retracted distally. A lot of fluid and hemorrhage.
Yeah, so another hamstring.
I would definitely repair this one.
Yeah, I think this one was surgically repaired. Yeah,
One thing you have to remember, and I'm going to ask whoever wants to answer,
it's Tayson's
Jason,
case. Yeah,
Jason, how much does a leg weigh in terms of force when you raise it off the bed in a straight position?
Like, how much does it weigh for you to hold it up while repairing it?
No, while you're laying down in bed and you're raising your leg, how much does it weigh
Um,
in terms of your body weight?
like 25%.
It's 75% of your body weight. You're
because
using a long lever arm,
because the
and so
long
it
lever
becomes
arm.
75% of your body weight.
Yeah,
So when you have that kind of weight, you got to be very, very careful about what type of things you do around the hip
Okay.
thanks.
and how you take care of the patient afterwards too. Like you roll the patient instead of having them raise the leg to get out, and so on and so forth. It's not a simple situation.
Robert,
Okay, here looking at the right hamstrings against, it looks like there's an avulsion injury there and some probably hematoma and surrounding fluid.
yeah.
Yeah.
So here we see the tendon on the opposite side. Here we don't even see the tendon, and it's significantly retracted distally all the way down to here with a large hematoma. Yeah.
Can you tell us how long it is? How long it's been?
How long it's been? I don't remember. Well, I don't know. This case is from Korea. Uh, I've seen several cases like this in the U.S. And a lot of them were chronic, in which case you see a lot of fatty atrophy of the muscle that's retracted. Here, I don't see much fatty atrophy within the muscle, so this is either subacute or acute. Uh, and we can see
And
some parts of the
then I
hematoma.
would fix it.
Yeah,
Um, but if it's really past 6 weeks, chances of trying to pull it back up there, it's going to be very difficult.
yeah. I think this is going to be less than 6 weeks, just looking at the way the muscle looks.
And you can try.
Okay. Elior.
22-year-old football player, one day after injury. um, yeah, here there looks like there's a tear at the myotendinous junction. The tendon at the ischial tuberosity, that looks intact.
So there's a tendon there. Probably some abnormality here. Here's the intramuscular tendon with a lot of edema and the kind of feathering appearance on either side. And then there's retraction of the musculotendinous junction. So the main tear is right in here. We can see a little hematoma. associated with it. So this was on 12/3/2022. This is on 1/12/2023.
Mm-hmm. Yeah, there's definitely less edema and fluid, but there's still laxity of that myotendous junction. Um, and okay, edema in the bicep femoris muscle.
Yeah, you can see a lot of edema here diffusely. It looks like the tendon is still torn and distally retracted. And this is either acute denervation, which was thought at the time, or this could be also acute development of atrophy due to acute disuse from the muscle tear, and you can get an edema syndrome within the muscle for that as well. I'm not sure why they didn't operate on this. Okay, Tayson.
All right, so on the right side, I think we have a retracted hamstrings tendon there with,
Normal here, retracted here.
yeah, it was some muscle edema and atrophy.
Right. Here you can see that the muscle is atrophic and edematous. Good. Here are the axial images, and you can see the fatty replacement of the muscle, decreased volume of the muscle, a lot of surrounding fat, and some edema within the hamstring muscles. Good. This is a chronic hamstring avulsion. Okay. And here we can see another bony avulsion here, and this young person. And this is more of a chronic appearance with cystic changes in the area where the bone is trying to heal.
That's repetitive, right, John?
Yes. Yep. Okay. And here's just a case where you have a tear at the ischial tuberosity. This patient had developed weakness and paresthesias more distally. And occasionally what can happen is that you can have a tear here. It can heal with scarring. The scar actually can involve the sciatic nerve. And here we have widening and increased signal intensity within the sciatic nerve. And if you follow it down, it's thickened. If you look on the axial images, what you can see is increased signal intensity and thickening of the sciatic nerve with kind of some fatty infiltration in the area here, which is they actually operated on this, and they found a lot of perineural scarring that they thought was secondary to the hamstring tear and the healing, which then produced a neuropathic syndrome involving that left sciatic nerve. Here you can see kind of a normal sciatic nerve on the right, and this is an area of thickened sciatic nerve on the left. And here's that area of scar tissue which is enveloping the nerve, normal on the right side, normal fat around it on the right side, abnormal scarring on the left.
Did it ever come back in terms of function?
I don't know. This is a patient from Australia, and I don't
Probably
really
not.
follow up on it. Oh, wait, let's see. I've got some further information I forgot about. So the patient had a second surgery, scarring, tethering of the distal stump, biceps femoris. No. Yeah, so I don't know, John. So let's talk a little bit about nerve injury. There's three mechanisms of traumatic injury to the nerve. You can have stretching injury, a laceration, or a compression type injury. And there are several different systems to grade muscle injury. The Saden's one, this would be normal. Neuropraxia is where you have a block of conduction, which we see here. Then you can get axontomesis, where you have a division of the axons where they're torn internally, but the overall nerve is still intact, and the neuromesis where you have a complete transection of the nerve itself. These last two typically are considered surgical, whereas the earlier one often will heal itself. Let's just talk. I think we talked about this before, but just to review the anatomy. You start on the outside by the epineurium, which encircles the entire nerve. Inside, you have different nerve roots. Each of these is surrounded by a perineurium, and inside the perineurium, you have the axons, which are also. So the axon is basically the wire that transmits the pulse. Then you have a myelin sheath, which is basically insulation, and an endometrium around that. And then you have all these bundled together to make a nerve root. And then in the middle, you have an artery and a vein. So a more recent classification system is a Sunderland classification. So if we do the Seden classification, you have neuropraxia. Sutherland divides it up into finer grades. You can have this neuropraxia is local myelin damage, usually from compression. And early on, this would be a grade 1 Sunderland classification. Then you get axonatomesis, and this would be a grade 2 Sutherland early. If it's low grade, the axon is severed, but the endometrium is still intact. A little higher grade axonatomesis, the axon is discontinuous, the interneural tube is discontinuous, but the perineurium and fascial and the fascicle is preserved. Then the most severe form is a grade 4. We have loss of continuity of the axon, tubes, perineurium, and fascia, but the epineurium is intact. And then there's the worst neurotomesis, or grade 5, with the Sunderland classification, which is complete physiologic disruption of the entire nerve trunk, usually from a complete severing of the nerve. Classic evaluation, you look at nerve conduction velocities and electromyogram. But in the first 3 weeks, both of these tend to underestimate the degree of injury. Physical examination also is very difficult to differentiate a surgical from a non-surgical lesion. So a number of people are now touting evaluating these with MR to try to better determine appropriate surgery, whether there should be surgery. So what are now called low-grade lesions include the Sunderland grade 1, 2, and 3 here. And then high-grade lesions, which are considered surgical lesions, would be a grade 4 and 5 under the Sunderland classification. So if you see an acute complete tear of the nerve, that's usually, if it's an important nerve, is indication for surgery and high-grade injury. So how do you differentiate these on MR? What they found is that the nerve size increases with grade. T1 signal increases with grade as well. PDF signal increases with grade. So thickening of the nerve, high signal in T1, high signal in PDF, fat sat, heterogeneity on T1 and PD fat sat are all concerning, but it turns out these turn out not to be useful in differentiating surgical from non-surgical lesion. What's potentially more useful is perineural fibrosis, which is present in high-grade lesions, architectural distortion in high-grade lesion. If you have bulbous enlargement, that's generally seen with complete tears. Discontinuity is obviously a complete tear. And if you see distal skeletal muscle denervation, that indicates a high-grade lesions. So these are the 5 criteria which are most reliable in determining whether the patient is surgical. Unfortunately, skeletal nerve denervation what you see more acutely after a day or two is edema within the muscle, as we saw earlier in one of the cases. Later on in the chronic, you start getting muscle atrophy, but at that stage, it's really too late generally to do surgery. Okay, I don't know. Who's next? Okay. I don't know. Robert, why don't you take this one?
Sure. It says new pain after repair. Looks like there's some increased signal and fluid at the yeah the proximal hamstrings, and then some muscular edema down there.
Yeah, and if you notice here, the actual marker is down here where you see the edema and atrophy of the muscle.
Right.
This is yeah. And that's where they had surgical repair up higher. But down here we see muscle atrophy and edema. And then here we can see on the axial images, the atrophy and the edema within the muscle. So this could be that the patient it has too much lengthening of the tendon, and therefore it's really not functional anymore. Or at the time of the injury, you could have damaged the nerve, and you have denervation, so it's not going to come back.
Robert, how fast does a nerve grow?
I'm not sure about the exact rate, but it's pretty slow.
1 millimeter a day.
So typically, if you reconnect the nerve, the distal axons are basically dead. The proximal ones are still typically alive, and then they grow into the distal nerve along using the nerve as a conduit to go to the right places, and it should get function back after about however many millimeters you are to where it's going times the number of days. Okay, Elior.
So here I see discontinuity of the tendon
Okay.
with edema in its place.
Yeah, and then you have distal retraction of the muscle, some hemorrhage around there. And so it certainly looks like there's a lot of edema at the musculotendinous junction, but there may be enough tendon here to repair. So this would be a case that is potentially surgical. If it were right at the musculotendinous junction, so you'd have to suture into muscle, then that's generally considered non-surgical. So it's a bicep rupture. John?
You might try to use mesh to support that, but that area is kind of a iffy.
Okay.
Because of the tendon is not that good looking
Right.
compared to the proximal portion.
Yeah, that's right.
And in this area, there's a lot of tension, and the muscle goes into spasm, etc. And the repair has to be really, really strong.
Thanks, John. Okay, Tayson.
All right, I see this probably in a torn tendon of the muscle there on the right. It looks very wavy. And yeah, edema in the muscle.
Yeah, probably edema or hematoma here, more distally. And then here we can see on the axial images, this area. And on the sagittals, again, we can see retraction of the muscle, but again, like John was saying, we really don't see a very robust tendon there.
Mm-hmm.
That was it. And
If you have spaghetti, you can't suture it.
And so this looks like there's a large injury here that's really involving the muscle. So I think this was thought to be non-operative. Okay. Robert.
All right, so here, looking on the right, looks like there's another avulsion of the tendon and a lot of fluid and edema.
Right. And here you have a little bit more robust tendon, so this is one that I would think, and it looks like it's probably avulsed off its bony attachment. So this is a potential surgical candidate, I think, here. And then we can see all the hemorrhage and edema within the muscle.
I'll go along with that.
Yeah. Okay, Elior.
Okay, 21-year-old college basketball player with direct hit to the posterior thigh. Yeah, we see edema in the muscles and maybe some fluid or hematoma tracking along the posterior femur.
Yeah.
Yeah. So maybe a contusion of the muscle.
Yep. So that was a short end of the biceps contusion. Good.
Ice and rest.
Tayson.
Some people use anti-inflammatories
Decrease the risk of
for two reasons. Prevent calcium deposits and pain.
right.
But the pain probably needs narcotics.
Tayson.
All right, so looks like we have a myotendonous junction tear.
Well,
Uh,
here we certainly see a lot of probably fat replacement. This is a T1 weighted image within the muscle. Here we can see that. This may be tendon here, but we can't really follow it all the way up to its bony attachment very well. And here are the fat suppressed images. What do you think of the PD fat set images?
looks like we have atrophy of the muscles there,
Yeah.
semimembranosus and semitendinosus.
And it shows the fat suppression. So this is kind of chronic fatty atrophy in that area. Yeah, and was a chronic tear. Okay, so why don't we move on to the gluteal tendons, the bane of everyone who reads hip imaging. So this is kind of the coronal plane. Typically, the gluteus minimus is kind of anterior and deep to the gluteus medius. We see here and here they attach to the greater trochanter in this area. This just kind of shows a lot of the anatomy. I don't think we need to go through that. And then we can also see that the muscles attached to the iliac bone, and this is basically the gluteus minimus anteriorly, gluteus medius kind of in the middle, and then the maximus is back here posteriorly. So the greater trochanteric pain syndrome, I think, is a very common cause of symptoms in middle-aged and older individuals, especially women. It's also called the proximal iliotibial band syndrome, and it's also called a rotator cuff tear of the hip. In athletes, it can be due to overuse with edema and partial tears, but I find it's pretty uncommon in athletes. Athletes are usually it would have to be an athlete who really is not well conditioned, who over exercises without proper conditioning, and then you could get it. You can see it in skiers, especially middle-aged skiers who sit around on their desk throughout the year and then go out and ski in the winter, and all of a sudden they fire those gluteal muscles and they can get injuries due to that. You can have direct trauma. But most commonly, we see it degenerative people in middle age and older, especially women, as I said. And you can get both, you can get fascial, tendinous, and also muscular tears in this area. And again, it's very similar overall to what we see in the shoulder. The supraspinatus tendon, we see many injuries in the shoulder and the gluteus medius tendons, we see is a very common cause of pain symptoms in the hip. And you can also get inflammatory bursitis. It can either be due to infections or due to systemic inflammatory disease. This condition is often frequently called bursitis in this area, though I think that's what many people call it, though it's actually rarely caused by an inflammatory disease of the bursa. You can get hemorrhage into the bursa, but it's most of the time it's a secondary hemorrhage or fluid due to injuries to the tendons. Okay, see, Elior.
Okay, so here,
Low field T1 weighted image. Patient's primarily symptomatic on the right, I believe.
okay. I'm not sure.
Okay, so over
Okay.
here, this is the gluteus minimus tendon. It attaches anteriorly. In that same location on the right side, we can see a lot of increased signal intensity. Here's the black tendon. There's increased signal intensity either due to a partial tear or tendinopathy. If we go to the coronal stir images, what do you see?
Yeah, we see a lot of edema and maybe tear and retraction as well of that
Yeah.
gluteus minimus.
So this is normal on the left, and we can see here's the gluteus minimus tendon. We're kind of out of the plane of its attachment to the greater tuberosity. Over here, we can see that the musculotendinous junction is retracted compared to the opposite side. We can see that there's a tear down here, severe tendinopathy of the torn tendon. And just like we talked about with the rotator cuff of the shoulder, in cadaver studies, 100% of torn rotator cuff showed pre-existing tendinopathy within the tendon. And I think the same thing occurs in the quote rotator cuff of the hip as well. So severe tendinosis of that gluteus minimus tendon, a tear, and hemorrhage into the bursa and surrounding soft tissues.
It's not uncommon for the gluteus medius to have a portion of it torn as well, John.
I agree. Actually, gluteus medius is probably more common.
Yeah.
They're both pretty common.
But usually it's a little piece of both.
Okay. Yep. I think that's right. Okay. Okay. Robert. I'm sorry, Tayson.
All right, so we see fluid at the greater trochanter there and some edema in the gluteus medius. I'll be thinking there's a tear there.
Yeah.
Tyson, you don't think that this is a old lady, do you?
Very muscular, if it is.
Thank you. You answered my question.
Yeah. And so here, this would be the minimus. The muscle looks very well developed compared to what we normally see with this condition. Maybe a little bit of thinning of that distal tendon at its insertion, but here we can see the gluteus medius is here, and there's a lot of edema and tearing of the gluteus medius tendon here, and some hypertrophic bone formation of the greater tuberosity, showing really a chronic traction injury at that gluteus medius insertion.
Sometimes what you need to do over the greater trochanter is you take the tensor fascia lata and incise it longitudinally with cuts transversely to take the pressure off the greater trochanter by the fascia lata that causes a lot of this problem.
Okay.
And it works pretty well.
Okay. And then here we can just see in the axial plane, anteriorly is the minimus, and the middle is the medius, and then the maximus is posteriorly there. Okay, Robert.
All right. Here it looks like there's some fluid where I would expect the gluteus medius to insert and maybe some atrophy.
Are you talking about this?
Yeah,
Yeah, this is a T1 weighted image here,
gotcha.
T2 weighted image there, PD fat set image here.
Okay. And in that case, there's just some trochanteric bursal fluid.
A little bit of fluid here, but
Yeah.
this is fat, right?
Right.
So that's fat.
Yeah.
And we can see a little bit of fluid there. And this is actually a little gluteus medius tear as well. Okay, Elior.
Okay, so here, let's see. Is this a T1 fat set or PD fat set?
Yeah, I don't know if it's T1 or PD. Since it's before contrast, it's probably a T1 fat set.
Mm-hmm. I think we're looking on the right. I'm not seeing a tendon on the greater trochanter there.
Here's the left. So this is before contrast. When I
Mhm.
add contrast, it looks like this.
Okay, so there's contrast enhancement.
So that is before, and that's after. So these are both T1 fat set images, right?
Mm-hmm.
And this just shows that I don't routinely recommend it. As you all know, I believe that IV contrast is grossly overused in MR of the musculoskeletal system. But it does increase the sensitivity for looking at these, especially chronic type tears. Like you, and then here we can see the tear of the gluteus medius on the right. Okay. Okay. Tayson?
All right. So I see a trochanteric bursal effusion.
Well, we see this. Do you think this is in the bursa?
Or is it in the, could that be in the minimus tendon?
Well, I think this is the medius muscle. The minimus muscle's over here. This is the minimus tendon. This is the medius tendon should be here. I think we're seeing a lot of increased signal intensity involving the medius tendon, the iliotibial bands out here.
Okay.
And here we can see that same signal. And
Tendon looks okay though, right? Right here on this axial images.
the axials, well, the tendon is going to be in here, and there's a lot of increased signal intensity.
Okay.
So we need all the images to show it, but this is not an atypical appearance of kind of chronic tendinopathy of the gluteus medius tendon. That's high signal intensity, kind of goes right up to the musculotendinous junction of the gluteus medius, and this is really chronic tendinopathy. It's not torn at this stage, but I think it can be symptomatic at this stage.
Okay.
Okay, Robert, pediatric case.
All right. Looking at the right hip, it looks like there's some fluid overlying that greater trochanter and some edema in the adjacent musculature.
And in the bone as well, right?
Yep.
Yeah, so this was trauma, and this was
Uh, so is that an avulsion injury?
yeah, I think it was an avulsion injury. You know, you'd have to mechanism. I don't think we can clearly always differentiate between impaction and avulsion.
Sure.
Avulsions at this age are not common.
Right.
It's
probably more likely impaction, but I don't remember the history now.
because the bone avulses, not the tendon.
Yeah. And this looks like this is primarily in the tendon and muscle with some bone disease here. And, right. Okay, Elior.
Okay, 42-year-old female with left hip pain. Yeah, the gluteal tendons look intact. There's might be some atrophy of that.
Okay, so here is a large field of view images.
Right.
If we go to the small field of view images, this is what it looks like.
Oh, okay. Yeah, some laxity of that. I think it's the gluteus medius tendon there. And some rounded low signal. Well, actually, no, this could be calcific tendonitis, maybe.
So just like the rotator cuff of the shoulder, you can get calcific tendonitis in the hip as well. So this is calcific tendonitis of the gluteus medius tendon. Probably the same mechanism that we get it in the supraspinatus and infraspinatus. Probably chemical changes which occur after trauma and partial tears. Okay. Tayson.
All right, 15-year-old male, right hip pain, 4 weeks, heard a pop. I think the gluteal muscles look similar. Oh, okay. Have at the right iliac bone, we have a small avulsion there.
Yeah, what is this?
That is
What attaches there?
that the tensor?
Yeah, fascial tensionata. And then there we can see that it's torn with a little bit of hemorrhage into the surrounding tissues. So it's proximal gluteus medius and probably the tensor fasciolata with a little avulsion injury to the bone, which we could see right here.
Yeah.
And then here's the gluteus medius right there and the tensor fasciolata here. So don't forget the anterior superior iliac spine in that area as well. All righty, Tayson.
All right, 45-year-old badminton player. Posterior thigh pain. Okay. Let's see. There's definitely a fluid collection there. Where is this coming from? Is this gluten maximus? No.
We can see atrophy more distally here. There's a CT scan. Back here.
A little lost right now. Let's see.
This is actually calcifications there. This is a muscles attaching to a ridge along the posterior lateral aspect of the femur here. Some hemorrhage in the adjacent tissues. Here's on the CT where you can see the calcification.
So I got vastus tear. Vastus.
Yeah. So this is the gluteus maximus inserts all the way down along through here. And this is a calcific tendonitis at the gluteus maximus insertion.
Okay.
So Robert, what do you think of this case?
All right, so we have a 56-year-old male, rule out tumor. There's a lot of fluid posterior to the femur there. Yeah, some, I guess, almost abrasive change of the posterior cortex of the femur there as well.
Yeah, a lot of edema here. Similar location to the last case. Yeah, and then this is another tear of the gluteus maximus insertion. This was more chronic with an avulsion, kind of an erosion at the avulsion site. Another similar case, again, the gluteus maximus insertion. There's some hypertrophic calcium deposits here, a lot of edema in the soft tissues. Again, another chronic avulsion injury of the gluteus maximus here and the posterior femur. Yeah, that's where the gluteus maximus basically originates and inserts along the posterior aspect of the proximal femur. Okay, why don't we stop here and we will start up again when I get back from vacation. All right?
Sounds good.
All right, thank you.
Okay, thank you.
Thank you.
Are you going to wait till the next Tuesday, John, and relax a little bit?
Let's kind of plan on Monday, and if I can't do it, I'll let everybody know. Okay?
All right.
Thanks, everybody.
Have a good trip, and everybody have a good day, week.
Thank you. Have a good weekend.